Morning. Welcome to Pediatric Grand Rounds. Two announcements before we get started. Attendings, once again, please sign up for your MOC points if you haven't already. This is the second point today. Janie has papers at the back, or you can sign up online to receive your maximum of 10 points for this year. And also, this is Dr. Davis's last day at Carilion. Chucky, bye-bye. All right. Oh, that was meant nicely. I think it wasn't. Today's speaker is Dr. Eduardo Lara-Torre from the Department of Obstetrics and Gynecology. He is professor with tenure at Virginia Tech Carilion School of Medicine in Obstetrics, Gynecology, and Pediatrics. Dr. Lara-Torre trained in Monterrey, Mexico, with a residency training at Case Western University and a fellowship training in pediatric and adolescent gynecology at University of Louisville. During his time at Carilion, he has served in numerous leadership positions, including currently serving as Vice Chair of Academic Affairs and the Section Chief of Academic Success in Obstetrics and Gynecology. He has served on numerous national and international educational collaboratives and has published extensively. He is the recipient of numerous teaching awards from the medical students. Please welcome Dr. Eduardo Lara-Torre.
All right. Let's test it. Can you hear me with this? Volume okay? All right. I don't stand on the podium. I hate the podium. It's the worst thing you can do to me. So when they said that they were going to do this on like telecast, and I said, there's no image, right? I don't have to stay there because then everybody gets frustrated when the speaker all of a sudden just goes away from the thing. All right, so today what I'm going to try to do is give you guys just an overview of adolescent contraception. Some of you might be doing this, some of you might not. And if you're not, then maybe you should start thinking about it, of doing it. Because remember, this is, you guys are our family docs or our internal medicine docs, right? You are the front line of these patients. There's a few of us in the country, and that's it. So you guys can do what I do. It's very simple. You just got to engage the kids, right? And I call kids anybody who's younger than me, but so kids, I mean adolescents. So that's what we're going to focus on today. I have no disclosures. I wish I had some. And, but we're going to really talk about contraception, some statistics about changes that have happened to adolescent pregnancy, some data about contraceptive methods and how they changed over time, as well as talk about some specific cases where you can maybe draw from these cases and use them in your practice, because this happens every day in every office. So that's what we're going to talk about today. We'll start with a case. This is a 15-year-old patient, and I'm not going to read the slides. I'm going to try to just give you some points. So she came to the office. The mom found with the boyfriend in the basement, and they were having sex. She comes to the office, and she promises to her mom that she's never going to do this again, and I heard that story multiple times and delivered multiple babies after that. And so anyway, she comes to the office, and she's got a positive pregnancy test, right? So it wasn't that basement event. They've been doing that basement event for a while, right? So just a funny statistic so you guys know, the #1 place where kids have sex for the first time is the basement of the boyfriend's house. So if you have a basement, you may want to be checking that basement out often if you have kids, all right? Good. All right, so this is the case. This is what we're going to work on. So thinking about contraception, unfortunately, kids seek contraception very late in the game. The average teenager is going to look for contraception at about 12 months after they start having intercourse, which means we're already very, very late because more than 50% of pregnancies will occur during that first 12 months of having sex. In fact, 1 in 5 teenage pregnancies occurs in the first month. So that, theory that adolescents have that, you can get pregnant the first time, yes, you can. You just got to try, right? So it is important to remember that because by the time they come to us as healthcare providers, we're very late in the game. So our job is to not wait for them to come to us, but for us to invest the time when they're coming in for something different and they're reaching that age of reproductive health, discussions, that we engage them, we talk about it, and we start bringing these topics up. Because we're failing right now. We're not doing super well at all. These are some of my favorite phrases. I have heard them all. These are quotes from Planned Parenthood, but I have heard each one of these in my office, right? And this is the reasons why kids want to have sex. There's so many things, right? I'm the only one in my group, get it over with, my boyfriend will break up with me, sex will make me popular, and that is true. It will make her very, very popular. She starts having sex with the high school, right? That's obvious. And, of course, I want to get back to my parents. So this is what's going to the brain of the kids. That's what we're working with, right? So just think about that. And that's why we fail, because all these things are going in their brains, and by the time we get them, all this has already occurred, right? This is the pregnancy clock. I like it because it gives you a perspective on statistics, right? How often is this happening? And this is important information because this lecture lasts 45 minutes. So if you have a 17-year-old girl, you may want to check on her right now, see what she's doing. Make sure she's not in the basement, all right? All right, so a little update on statistics. We have done a pretty good job in the last 20 years in decreasing teen pregnancy. We actually have done a pretty good job. When I first started giving this talk 10 years ago, we were doing a terrible job, right? So the graph was not super pretty. It was actually terrible. We were the highest country in the industrialized world with teenage pregnancy. We were failing at contraception. We had an abstinence-only platform from the government for contraception, and we were not doing well at all, right? Thankfully, some of the strategies that we invested on, in the early 2000s and then late in, after 2010, started creating some changes in this pregnancy rate to decrease the birth rate dramatically. So a drop from 60 to 20, that's a huge change in 20 years, right? So we must be doing something right now that we were not doing well before, and that is important. For those who are visually driven to know what's happening, right, look at that. Very nice drop, huge drop. We did a good job, right? So what did it? It's kind of hard to predict exactly what did it. But I think that all these things have something to do. We had decreased costs because we have more access, and it was free for people to get it if they had any type of insurance. It is also the state started giving it for free, started setting up more clinics for people to have access to it. We started doing it immediately postpartum around the country, right? So we were not waiting for them to come back 6-8 weeks later and never come back, right? We were motivated teens right after birth, boom, contraception right there and then, right? So IUDs or implants right after they deliver because they're motivated, right? They're right there. I don't want to go through this again. I'm 15. Let's do some birth control. Excellent, right? So right before you leave the hospital, we'll do something for you. We also likely are seeing less sexual activity, delayed a little bit more, and those who are having sex are probably having less number of partners. And that is important because that is helping the overall, reproductive health of this group. And although it's still happening a little bit less. So maybe some of the education that we have put out, right, that comprehensive, contraceptive education, not only abstinence, but the availability of methods is helping finally deliver that message to decrease sexual activity. And probably the increase of long-acting reversible contraception. That's what LARC means, long-acting reversible contraception. These, it's mostly we'd call IUDs and implants on that category, right? So yes, this has gone up significantly in teens. Again, statistics because you need to know it. So less kids are having sex. Less kids are having sex before the age of 13. Less number of partners. More condom use. More contraception use in general, and increased use of LARCs over the last years, right? So just to give you perspective, this number in the United States in 2015, 4.2. Europe, 26.5. Just throwing it out there so you get perspective. So yeah, we're doing great, but we're way, way behind the 8 ball, right, compared to other places. And so our pregnancy rate is still not super awesome, right? So when you talk to adolescents, what are they looking for? So how are you going to convince an adolescent that this is the best thing for her, right? So they're looking for these characteristics in contraception, right? They want to make sure that it's safe, that it's well investigated, so you're not testing things on them, make sure that it's long-acting, but also that it's highly reversible, right? So they want it to last a long time, but also if I want it out right away, I want it to be able to have babies right off the bat, right? And they're thinking about these things. This is important because kids come in two flavors, the one that never wants to have a period and the one that wants to have a period every single month so she knows that she's not pregnant. It's true, right? So when you're talking about adolescent contraception, you got to ask them what they want. And you got to try to give them what they're looking for so that way they stick with it, right? So if the kid wants to have a period every month, maybe I'm not going to give her an IUD that is going to take her period away. Why? Because she'll freak out and 3 months later take it out. Well, that didn't help anybody, right? Maybe I'm going to put it on something that makes her bleed once a month. Why? Because it keeps her happy and it keeps her using it. That's what I want to do, right? Questions so far? I'm going to pause for questions after each case. Yes? We think it's the decrease in sexual activity. We think it has something. So the question was, for those on the phone, how do we explain the decrease in sexual activity? The most likely answer to that is that we're finally reaching the audience with comprehensive education. When you talk to kids, and this has been tested in Europe for decades, when you talk to kids, remove the taboo of sexual activity and actually explain to them and show them the consequences, the risks associated, the benefits of pregnancy at a later age, that actually makes a change in their brains in deciding when they're going to start having sex and how often and how many partners. And this has been tested in Europe very well. What doesn't work, and we have very good data on it, is just tell them don't have sex. That does not work. We did it for 20 years, and instead of going this way, we went up on the table, right? So abstinence only has been tested, it's been studied very well, and it doesn't work. When we started modeling our education like Europe did and started putting, let's talk about contraception as part of this discussion, then we started seeing the flip, right? So that is, I think, what is causing the change. All right, moving on. So getting a little older here, but, you know, she could be a 13-year-old who likes to do gymnastics, whatever you want to do. All right, this is a patient who's about to be deployed to Afghanistan. She used to be on the pill, but she's unsure how she's going to accomplish this now that she's going to be deployed. She also doesn't know how she's going to deal with her menses. She's got a negative pregnancy test, and she has not had sex in 2 months, right? That's who we're talking about. So first question, how do you want to handle the questions? Just leave it in there, people read it, right? And then they raise their hands, or they have a sheet, or what are they? They know what to do? Okay, sounds good. All right. So this is the question. When is the best time to start a contraceptive method? Think about the patient we just saw, right? This lady. You like it? I like that, yeah. So who's going to do A? I got notes. Okay, you get, there's a lot of you people here, so I'm going to see some hands going up. All right. A, anybody? No? Anytime is fine? Okay, all right, no takers. Only during their period. All right, I got a taker in the back. Good, good, good. All right, how about the Sunday after their next period? A couple of hands went up. Okay. How about today before she leaves the office if she's not pregnant? Oh, we got a few takers. Excellent. And how about the last one? Contraception is not for young people. They need to have babies to keep OB&Ps busy. I like that one, yeah. All right, so sorry the letters didn't make, all the letters made it in there, but the answer correct is D, right? D is good because you have a motivated patient. We talked about postpartum contraception briefly, right? The kid just had a baby, doesn't want to have another baby, super interested. You talk to her about birth control and she's going to take it. Patient's in the office. She came in to 6 weeks birth control. She's motivated to do it. Oh, hold on, let me give you a prescription and wait another 6 weeks before you start it. How likely is that to happen? Right? So 2/3 of prescriptions of contraception given that way go to the trash. Right? So the best way to do this, oh, you're here? Okay, you're not pregnant. Here's the first pill. You have a great day. Out the door, right? So that technique actually is shown to increase compliance long-term, not only for the first block, right? Compliance long-term, and overall decreased pregnancy rates. So we call that the quick start method. You're here, you're not pregnant, pow, contraception, let's go, right? So there's a lot of ways to do this. One is, for this particular patient who wants to have less periods a year, we can use, instead of the cyclic birth control, you give them a pack and they bleed once a month, and, we give them a fake period every month just because we can, right? So you can do that and torture them like that, or you can use other things. You can start extending their cycles. Now, you watch the commercials about these products, and I have no investment in any of these companies, but you talk to these, you see the commercials and they promise 4 periods a year, right? The reason why they say that is because it comes packaged with 3 months worth of pills, and then they have a week of placebo on the package, right? So the advertise says 4 periods a year. Clinically, that doesn't work out that way. Everybody has breakthrough bleeding before the 3 months are up, and very, very, very few patients are going to achieve 3 months of amenorrhea when you use the pill continuously, meaning no placebo, right, all the time. So what I do with these patients is I extend it a week at a time. Instead of just saying, here is your package of 3 months of pills, take it, what I do is we're going to start with a month, have a period. Next time you start a new package, you're going to go 5 weeks instead of 4. And then in the next one, 6 weeks. And I keep adding a week at a time as long as they don't have bleeding in between, right? So I get away with as much as her body is going to let me. Some kids go 10 weeks, some kids go 12 weeks, some kids go 6. And that's as far as I can get with them. Because once they start having breakthrough bleeding, there's nothing I can do to stop that breakthrough bleeding. They're just going to have breakthrough bleeding all the time until they get to the placebo, right? So just doubling the dose, tripling, 3 tablets a day, all that kind of stuff that we play with, it just makes them throw up and abandon the method. So what I do is, if you have breakthrough bleeding, it means your body wants to bleed, give her 4 days off, and start again where you left off, right? So that maximizes the number of weeks I can get in without bleeding and utilize the method the real way it works in the clinical setting. Like I said, there'll be a few people that do that. They actually created a product that had no placebo. You just take 1 a day every day. It's just all the time. Terrible breakthrough bleeding. It, actually was removed from the market. It's not for sale in the U.S. any longer because nobody bought it because they were having breakthrough bleeding all the time. All right, so those are some things that you can try to get your kids to have less periods, to, hopefully be happier with the birth control method they have and not kind of really put them into you have to have a period once a month. And remember that the pills that, the packages of the pill have 7 days of placebo, most of them. There's a few that have less, but there's no reason to have 7 days off, right? In fact, the more days off you give them, the higher the risk of ovulation in pregnancy, right? So the shorter the placebo you give them, the better effectiveness they're going to have, and the shorter the period is going to be. So marketers were very smart on this, and they created products that now are 24 active pills and 4 placebo pills instead of 21/7, right? So it gives them a shorter period. They still have a period once a month, but they like it better, right? So that's the thought behind it. You don't need 7 days. 7 days is an arbitrary number of days, and it's probably the wrong number of days to give them off. All right. When we look at the safety of utilizing the extended birth control, the first thing you moms ask is, hold on 1 second. She needs to cleanse every month. What are you doing to her? She needs to have a period once a month, right? Because the moms were taught that when they were kids. And they tell you, this is true. Every once a week, I have a mom that tells me, what are you talking about? She doesn't need to have a period, right? And the answer is no, she doesn't need to have a period as long as she's taking the medicine, right? So it's safe, it works, better compliance, so there's no reason why not to utilize it. The quick start, just touching a few things that people sometimes are afraid of is, one, if she's pregnant today, is she going to have a problem, right? So let's say she had sex yesterday, and today her pregnancy test is negative, right? But we really don't know if she's going to get pregnant this time, right? Because you need to let it cook a little bit before the pregnancy test comes back positive, right? So theoretically, if you have a patient that you're going to start something right away, and you say, well, you had sex recently, but today is negative, I'm going to put you on the pill today. One of the fears is it going to mess up the baby? And the answer is no. There's no teratogenic effects of the pill. So even if the patient happens to get pregnant with that last episode of unprotected sex, you're going to find out earlier than she's going to find out because she's going to finish the pill pack and not have a period, and pregnancy test positive, right? So you diagnose it at 4 weeks instead of 20 when she comes into the office, right? So it is safe. Other people think that it's going to increase the breakthrough bleeding if you wait until they're on their period to start the pill. And some other people think that it's just starting the medication in the office is going to bias in some way the perception of the kids that you're pushing contraception to them, right? And the answer to all that, we studied this, we looked at it. Kids who start the method, whichever method you like, in the office the same day, they will stay with it longer, they have the same side effect profile, but they're more likely after a year to be continuing on it. So there's no reason to delay the start as long as you know that they're not pregnant. You know, reliably can rule out pregnancy, right? Whatever that might mean in your brain. Pregnancy test is negative, here's the pill. You have a great day, right? We tested it on Depo-Provera, the injectable, and it was the same results. We tried it with a vaginal ring, same thing. The beauty of the vaginal ring, if you want to do a quick start, is that some kids are afraid of using something in their vagina. So for those of you who don't know what a vaginal ring is, it's a little plastic circle that has a combination of estrogen and progesterone on it, and you wear it 3 weeks on, 1 week off. So that week that the ring is out, you have a period. So the best way to engage these kids in the office is, oh, look what I have here. It's a ring. You want to try it? Here, put it on before you leave in the office. And you're going to see that you can't feel anything. So when you do that, then you get more buy-in from the kids. And this is actually a pretty good method for them because it's very private. There's no pills laying around that the parents are going to find out, right? They can just grab it, put it in, throw things out of the trash, and nobody will know that they are using a ring. So for those kids that are using this without their parents knowing, it's a pretty private, good method to utilize, and they're still cycling, right, and getting all the benefits of having both estrogen and progesterone. So don't abandon the ring. It's a good one. This is actually one of the few samples that we still have in the office. You know how Carilion has that policy that you can't have samples any longer? Because we teach how to use it, we get away with a sample on this one. Questions about the quick start, a couple of those methods? Yes, in the back.
So you think we're talking about for someone going to limit, is she also somebody consider option for about LARC?
So the question is, in that patient, would you consider LARC? Absolutely. But I saved it for the next slide, so that's why. Yes. So, you know, truly, let me tell you how we have actually changed. In the old days, I like all the old days is like more than yesterday is the old days, but in the old days, we used to counsel contraceptive the wrong way. We would start with abstinence, and then we would talk about condoms, and then we would talk about the pill, and then we talk about the shot, and then we would talk about the IUD, right? We kind of neglected the IUD at the end. In adolescents, if you think about their concentration time, you lost them at abstinence, right? So you got to capture the education with the best in front. So we actually do now is we reverse our contraception counseling. We talk about IUDs and implants first. We talk about the shot. We talk about pills, patches, and rings, condoms, and then maybe we'll touch on abstinence, right? And the reason to do that is to grab the attention of the person right off the bat for the most effective, long-acting method that we can have. And that helps. And now the books are switching to that way, right? In the old days, also the books would start with that. They contradict abstinence, and they would talk about all the statistics, and then the female condom, and it will go down the line. Now, the first thing that you're going to see, this is the pregnancy rates, first method, IUDs, boom, right? So we are finally making that reverse change, because if we don't change how do we educate ourselves, we're not going to change how we're going to educate the patient in front of us, right? So that's actually something that has changed. It's good. It's a good thing. All right, different patient, 17-year-old sends to your office. The mom has a history of a DVT in pregnancy. The mom was found to have a factor V Leiden mutation. The pediatrician tested the patient, and she was found to be positive. So now we have a patient that has a predisposition to have a DVT, right? Here it is. Oh, I can use some of these things. So what do you think? Next question, what contraception would you offer her? There's the list. So A, anybody? Give us the combined birth control pill. No takers? No takers. We do have hematologists in the audience, so, right? No takers. Not that. Just in case you answer wrong, he's going to know. All right. Vaginal ring, anybody? No vaginal ring. All right. How about a patch? No. How about Depo-Provera? Who's going to give her Depo-Provera? Ooh, we got a few takers. Yeah, and Dr. Edwards raised his hand, so, okay, this is good then. If he raised his hand, then we're all good. All right, condoms only. And how about nothing because kids shouldn't be having sex? Who picked that one? Yeah, that's exactly right. No, bad answer, people. All right, so the answer is use progesterone only contraceptives, whichever you want to pick, or you can use, you know, the copper IUD, which has no hormones on it, right? So you can pick from any of those, and the advantage is that we have a variety of these methods nowadays, right? We have it in pills, we have injectables, we have implants, and we have 4 types of IUD, actually 5 types of IUDs now. That's a lot, right? 20 years ago, there was 1 IUD only. That was it. The copper IUD was the only living. Now we have 6. That's great, right? So talk about a few of these. You know, the Depo-Provera is a very good alternative. It has terrible reputation, specifically because there was a study published that talked about bone mineral density loss with the chronic use of Depo-Provera, and that gathered a little black box warning into Depo-Provera that specifically target adolescents. Said if you have adolescents, they shouldn't be used Depo-Provera for more than 2 years because it's bad for their bones. Well, we jumped the gun a little too fast on that. There really is strong data that suggests that if you stop Depo-Provera, which eventually they'll do, all the bone mineral density recovers and it becomes exactly what it was before they used it, right? So even if it's used during their adolescent years where they're accumulating bone, it recovers itself. So because it recovers itself, there is really no reason for us not to utilize Depo-Provera as a valid, good method of contraception. And in fact, there's a lot of kids that love this because they get a high amenorrhea rate, and it's every 3 months, so they don't have to think about it. So those are some important things to think about because for a very long period of time, truly OBGYNs abandoned this method. They wouldn't even offer it because of the black box warning, right? So now that the data is coming out a little bit better, then we can actually tell that the bone mineral density returns, and it's probably time to remove the warning, but once the FDA puts the black box for it, it's there for good, right? So there's no need to stop it soon. You don't need to check their bone density either. That's another common thing that I see in my office. You know, they come in for a consult for prolonged use of Depo, and they come in with a bone mineral density. I'm like, okay, you know, what am I going to do with this, right? So don't order bone mineral densities if you're people on Depo. Just leave it alone. It'll be fine. Don't worry about it. And honestly, it was actually our paper when I was in fellowship that created the whole shebang. Because I published the data on bone mineral density loss, and it just went rogue. Horrible. So I feel terrible. So I'm doing these talks to get everybody to get back on board and feel better about myself. We can also use the single rod implant. It lasts for, currently it's approved by the FDA for 3 years, but we have pretty good data that goes up to 4, except on those who are over a BMI of 30, which is kind of half of the country, right? So in those who are with a BMI less than 30, we have very strong data that it actually lasts for 4 years, but we haven't changed practice. We're still using it for changing it every 3 years if we need to. Easy to put in, easy to get out most of the time. Very, very effective. The Pearl Index is the likelihood of pregnancy over a period of time, and it's 0. It is the most effective method of birth control we have available in the market, except not having sex, but that generally doesn't work well. It is, the bleeding patterns is the problem. So most of these, the kids either want no period or a reliable period. They don't want anything in between. And unfortunately, this particular method, although it's wonderful for birth control, the bleeding pattern is a disaster. It's unpredictable, it's often, and it's annoying. 3 things that adolescents hate, right? So we put a lot of these in, we take a lot of these out, regardless of what we try to do to make them to keep it, right? We try giving them a little bit of estrogen if they're bleeding. We try to convince them that this is going to get better over time, but the fact is that it's so unpredictable that it comes out very often. But we do use it. For adolescents, specifically data, one of the very encouraging data that has come out is that if we use it immediately postpartum, it actually has a better bleeding profile, and kids are more likely to keep it. So we are really investing a lot of time and effort in convincing adolescents postpartum to choose a method, whichever they want, but talking about implants postpartum is not a bad idea because their bleeding pattern is going to be better, and they're going to keep it because of that. So we push it. So Carilion now has immediate postpartum contraception. It took only 10 years for the state of Virginia to decide that it was a good idea to offer postpartum contraception. They wanted us to wait until they came back for their 6-week visit, you know, with a show rate of about 20%, right? So that's when we're supposed to have the contraception discussion. So finally, Medicaid, which is the majority of the deliveries we do in this hospital, decided that, if we give contraception immediately postpartum, they're unlikely to become recurring clients and spend more money. Maybe we should pay the docs to do this. So now we do. So they unbundle it. Now we can bill for the delivery, and we can bill for an IUD or an implant on the same hospital stay. And that then has created, we put about 15 implants a month postpartum and about same amount of IUDs, right? A year ago, it was 0. We were not doing any of these stuff, right? In only 10 years. And there's about half of the country that still doesn't do it because the insurance doesn't pay for it. Things to think about. So we're ahead of the game, which is great. So intrauterine contraception, this is we're going to touch on IUDs. It's not been very popular in teens because there is a lot of stories out there, quote unquote, about bad things happening to people who have an IUD, right? And this is kind of still lingering in the minds of a lot of providers who were educated during the time where there were some bad stories about IUDs. There were, you know. The 70s and 80s, we had an IUD that predisposed an infection, which created infertility, and because of that reason, that stigma to the IUD remains, that it causes infertility, and that it also predisposes you to have an infection inside of your womb and your pelvis, right? So it's terrible. And if kids are not monogamous and they are at risk of STDs, why am I going to give them an IUD? I'm like promoting badness to them, right? So those are some of the fears that we see. The other thing that people are a little hesitant when they put IUDs is going to be super hard because they never had a baby. So they would reserve IUDs only to those moms who had a baby, right? Well, there's a lot of other people that can benefit from this that never had a baby, right? But they were afraid because maybe the cervix is going to be too tightly closed and I can't do anything about it, right? We studied adolescents here in Carilion Clinic that were using the IUD. They keep it. A year is better than no year. Most of the times, the levonorgestrel IUD seems to be better well received, less bleeding, so tend to be kept a little bit more often. A few things that you can do in order to make your patients kind of sign on to the idea of an IUD is talk to them about all the other benefits that an IUD is going to have for them. And I'm talking exclusively right now about the levonorgestrel, right? It can help them improve periods, 60% amenorrhea rate if you use the higher dose IUD. Takes away your dysmenorrhea because if you're not bleeding, you can not have pain with bleeding, right? So dysmenorrhea, pain with bleeding. No bleeding, no pain, right? It also can treat endometriosis. It doesn't cause PID. It actually prevents PID, right? So the IUD works by thickening the mucus of the cervix. So if they have chlamydia when I put it in, then yes, I just gave him a little higher dose of chlamydia up in the uterus and they might have an infection, right? But if they don't have chlamydia when I put it in, then the mucus is going to thick so much that it's not going to let sperm go up and it's not going to let chlamydia or gonorrhea go up. So the risk of PID is actually present at the time of insertion. So with proper screening and appropriate screening like you should do anyway, you're going to prevent that from happening. And even if they're positive, you're going to treat them and keep the IUD. You don't need to take it out. But once it's in place and it's settled, they're actually going to have a lower risk of PID. They're still going to be colonized in the cervix, don't get me wrong. The rates of chlamydia are going to be the same, but at least it's not going to go back up, right? So other things that we have talked about is how can you put it in easier, and we have tried a bunch of different things. You know, pre-procedure NSAIDs, we have given them some misoprostol, which helps the cervix soften a little bit. And all these little techniques have increase the success rate in inserting it in people who have never had a baby. And that is what we need to distribute to everybody to know that just because she's 16, it doesn't mean she cannot have an IUD, you know? And I'm not asking the pediatricians necessarily to do it. If you guys feel like you want to do IUDs, that sounds wonderful. But if you don't, as you're talking to them about options, don't forget about the IUD. It's 5 years, right? And now we have very good data that it goes to 7. So once they put it in at 16, they go all the way through college with it, right? Just some thoughts. Don't forget about that IUD. It's very, very important. We are going up on the utilization. Interesting enough, those who are foreign-born are using it more. Why? Because it's commonly used in their countries where they're coming from, right? I just talked about the difference between the U.S. and Europe. So if they're coming from somewhere else, IUDs are like candy, and they're free. So that's why they get it. Hemoglobins get better, so I particularly only use it for contraception, but I have a lot of patients who have an IUD where I'm managing menstruation for whatever bizarre reason you can think of, right? So they're autistic and they need some management, or they have a bleeding disorder and they need bleeding management, whatever you're thinking of. All these kids benefit from that because their amenorrhea rate is so great, and if they're going to bleed, it's going to be spotting. So it is actually a very good method to utilize in those ones that you really want to bleed less. This is just to touch on postpartum. We talked about it briefly, but postpartum contraception, both the implant and the IUD are approved for immediate insertion, right? It's safe. If you don't know the CDC little numbers, 1 is go for it. 2 means go for it in case, unless there is something really, really, really wrong with the patient. 3 is if you go for it, be very careful because something bad may happen. And 4 is don't go for it. Don't use it, right? So everything is really category 1 and 2. Breastfeeding or not breastfeeding. You know, some people think that if you give a birth control method during a breastfeeding time is going to decrease the milk supply. We have no data on that statement. And it's very well known in the community that if you use birth control in any shape or fashion during breastfeeding, it's going to cut your milk supply. That, I don't know where it came from. Doesn't have any data to support it. The breastfeeding rates, growth, and supply, when tested appropriately, is the same if they're using an implant, Depo-Provera, or an IUD that if they were using nothing. So there is no data to support that statement, regardless of whatever somebody else might hear. So in this hospital, we had to change some people's perceptions about contraception and do a lot of education about breastfeeding and using progesterone-only birth control, right? So if you go across the country, everybody gives postpartum Depo-Provera before they leave the hospital. We didn't do that here because there was that perception in the community that it did. So it's good to fight perception with data and education so that way you get people on board and motivated to encourage their patients to have reliable birth control and space out their pregnancies to whatever they want to space them out, right? Some people don't want it, that sounds great, but if they do, let's give them the best we can. Same thing with the copper IUD and the levonorgestrel IUD. The only time we don't use them is if they have an infection in the uterus because that just makes sense, right? You don't want to put something in when there's an infection. Talked about this a little bit. A few things that you're going to see when you use it immediately after you put it in, especially the IUD, is that obviously it's going to come out a little more often. So it's going to have an expulsion more often. Why? Because the uterus is actively shrinking and actively passing clots once in a while. So it is more likely that it'll come out. But the rate is 15% expulsion. Don't think about 15%. Think about the 85% that stay in. That's what matters, right? Because before we were doing this, it was 0% staying in, right? So that is the change about IUDs postpartum. Then now, 85% are staying in that wanted an IUD compared to 0, right? So we are hoping that after this year we've been doing this, that we're going to see our teenager pregnancy rate in the hospital itself begin to drop down a little bit. Of course, we're using it in teens and adults. We're not just for teenagers, but we'll hope to see that. Today, if you ask me, it's not working because labor and delivery is as busy as it's ever been. It's out of control. But it is hoping that overall this is going to get better over time. If you're interested in what I do for a living, we have a society that helps you with educational tools to take care of these adolescents. You can find free educational forms for teens that are designed for teens as a language of the teens. It goes over the common conditions. We have some in Spanish as well if you have some Spanish-speaking patients. And we have a lot of resources at our website that are accessible without being a member. Of course, we want you to be a member. Of course we do. I am the president-elect of our society, and we encourage anybody who's interested, if you need more information, talk to me, and I can talk to you about what we do, what things are beneficial for pediatricians and others, and hopefully get you engaged into this topic. Because adolescents are an underserved population. You know, they are kind of abandoned in the corner between the adults and the kids, and sometimes we forget that they need as much help as anybody else does, and at a very specific time of their lives where there's a lot of confusion in their heads. So the more people we get to sign up to help them navigate those ages, the better we're going to do. There is also, you know, books that you can try. There's also an annual meeting you can attend if you want to get more familiar with this stuff. And again, most of the people who do this for a living, we are not necessarily, you know, I'm fellowship trained, but most people who do it are not. This is people who develop an interest, started seeing the patients, and became very comfortable with it by attending some of these meetings and getting some of these topics covered, and then they just do it, right? So you don't need to have a fellowship to care for these patients. You just got to know the population and know the common things that we see, right? All right, so just wrapping it up, the good thing is that we're utilizing LARCs a little bit more often than before. There is tons of available options now for kids. There is Skinner, quote-unquote, Skinner IUDs that you can use on your adolescents that maybe will make it a little easier to put in. I haven't seen that clinically, but wherever it's worth, you can try that. Our teen pregnancy rate is way better than it was before, and we had a study called, right here in the bottom, the CHOICE study. We have very good, reliable data that if you make it free and you make it accessible, 70% of adolescents are going to choose a LARC. Free and available. Those are the only two conditions, right? And right now, it is mostly free, right? Even if whatever insurance you have, it's covered. And if you can't pay for it, the health department will give it to you for free. So it's free and it's accessible. There's a lot of places where you can get a LARC, right? So if we continue to disseminate this information and remove the barriers, we're going to increase that number that we're currently doing in the U.S., right? ACOG and the AAP are in the same boat about IUDs and implants in teens. They both support it. So for those who would say, here's an OBGYN tell me about birth control, but, you know, I'm a pediatrician, well, there you go, right? Your society actually supports this. We came out with a combined committee opinion about the use of LARCs in teens, and they support it as much as the gynecologists do. So there's no reason to feel uncomfortable talking about these methods to adolescents. And I just put a couple of things that they talk about in there. This is a common question that I get. You know, am I going to get weight? Am I going to gain weight with this method? And the answer is no, you're going to gain weight because you're not doing anything and typing in your phone. But it's not going to be the birth control method that is doing that for you. So that is important to remind them that. All right. Remember the immediate postpartum. They're motivated. Let's get it done over there. The bad is that compliance and continuation rates are still bad. So although we're getting more kids on board to use contraception and they're using it more often, their interest kind of trickles out. And then eventually either get it out or forget. So if we can commit them to something long-term that is easy on them and they kind of forget about it, more likely they're going to stay with it, right? So if I put an IUD and it's good for 7 years and you don't have to think about it until 7 years from now, then maybe they're going to stay with it instead of you got to take a pill every day. That's very likely to eventually get very old and very boring, right? And although our pregnancy rates are significantly lower, we're still the highest, no matter what we've done. So we still have some work to do. So the ugly is that we still have a lot of providers in the OBGYN world that are afraid of using IUDs in teens. There is a lot of miseducation out there. So we're actively working. So pretty much every meeting of OBGYNs you go to nowadays, there is a session on this, right? So I call it we're being LARCed to death. That's exactly what is happening. Because everywhere you go, there's a talk about LARC. LARC this, LARC that. Why? Because there's so much misinformation, even in providers, right? we're training a total new generation of residents, which they're growing up with the IUD first, right? So this eventually is going to change. It's just going to take time for all these new providers that we're training and graduating to, make an impact on the field. So I think this is going to change. Our numbers are going up. I expect in the next 10 years that's going to at least double, if no more, because of how much effort we're putting into this activity. So for those of you who want to do it, let's talk about it. I'm available. My office hours are from, no, I'm just kidding. But yeah, let's make the change. You guys are the forefront of talking to these kids. If they bring the topic, great, engage them, talk them about the LARCs and then about the other ones. If they don't bring it up, then you bring it up, right? That's on you. Because they're right there for their sports physicals, for the, the track team this week. Have we talked about your periods and birth control and all that? No? Well, let's talk about it. I know it's the 5-minute appointment, right? And it turns into 3 hours. I get it. I get it. But, they're in there. They're captive audience. Talk to them about something else besides, their acne or something. All right. So that's my email. If you have any questions, of course, I'm available after this also. But I'll take some questions about all these topics from you guys. And thanks for having me. I appreciate it.
Sorry. That was a nice talk. I wanted to know what recommendations you'd have from a public policy standpoint, because as you talked about, increasing LARC usage in the teen population is going to greatly reduce the risk of teen pregnancy, save a lot of money for the, for the country as a whole and for the healthcare system. But still, there's, the biggest issue with LARC right now is attitudes of adolescents and their parents and some providers as well. So what kind of recommendations do you have as advocates that we can do?
Well, I'm going to take my Carilion hat off so I don't get fired. It's all right. Vote in November. That's all.
Editorial.
I get kicked out. So the key here is the government policies need to match the needs of the population, right? When you have a disconnect between the needs of the population and governmental policy about providing healthcare in any shape or form, it is likely that the healthcare is going to suffer, right? The patient at the end is the one that's going to suffer. So when these two are not talking to each other well, we're not going to fix the problem. We need them to talk again. And right now we're in a period of time where a lot of the investment in advocacy is protecting women's health, right? So we're investing a lot of time in saying all the gains that we had for the last 20 years in women's health, let's not revert them back to the 1920s. And that is where really most of our societies are investing their time in trying to maintain. Because we had a lot of gains, and now we're kind of like steps back, right? Or 8 steps back, actually, right? So we have tested the policy that is beginning to curl up again, and it didn't work. We did horrible on it, right? So that's what I'm trying to talk about, is the policy of healthcare needs to align with the needs, and right now it's not, right? And it's rapidly being reversed, and that is very scary.
Any other questions or comments in the room? Yeah.
Say you have an adolescent female who comes with her mother. Is it best to bring up this conversation as kind of a team with everyone on board, or to kind of talk to her in private to kind of get her opinions first?
It varies from patient to patient. There is some kids that their parents actually are the ones bringing them to talk about birth control, even if the kid is not sexually active. So that is a very open conversation as a general discussion, right? So you can have the general discussion with that parent and kid, but you don't get into the specifics, right? So you don't interrogate the kid. It's like, how many partners have you had when you started having sex in front of the mom? Because you're going to get a biased response to that, right? But the general topic, if it's brought up by the parents, then it's fair game, right? If it's not brought up by the parents, and this is something that you're going to bring up, it is probably best to bring it up when you have your 5 minutes of confidential time with adolescents, right? So all adolescents visits should have some type of confidential engagement. You should give them the disclosure about what confidence means and all that, and, confidentiality means. And then during that time, you can engage them about the risk factors. So when you're asking them about risk factors by themselves, all these things might come up on board. And if they don't have any risk factors, then you talk to her about have you ever thought about having sex at all? You know, and you'll be surprised how many kids said, yeah, oh yeah, we talk about it all the time. I just haven't started. All right, so let's start you now before you start, right? So we don't get into the first slide that we saw with timing. But I think it can be approached with the parents or without the parents. It all depends on what the dynamic of them two is, right? So the other thing I don't do is I don't force contraception on people. So that's another thing that I see patients for all the time. You know, it's the foster kid that comes in with a social worker because they don't want her to get pregnant during their foster time, right? And they say she needs to be on depot. That's chief complaint. Social workers think she needs to be on depot. That's the chief complaint, right? And then you talk to the kid, and the kid is like, what? Well, I don't even know why I'm here. I'm not having sex. I'm 13. And okay, well, all right, we're disconnected, right? So you have to approach also those because it is not unusual when you're seeing kids who are under foster care or they're, for example, in residence in some type of home because of violence or abuse or whatever it is. Those kids sometimes are coerced into receiving contraception. And we got to be careful we don't do that either, right? You got to promote it, but you're not going to force it on somebody, right? That doesn't make any sense.
Any other questions or comments in the room? Yeah.
I was wondering, is there any medical situation where you would choose a lower dose IUDs for adolescents versus the Mirena?
Like, what are you thinking? I'm going to reverse. I'm going to do psychology and reverse psychology. So what are you thinking?
I know that the higher dose is better benefit for amenorrhea. Mm-hmm. So I would think that you wouldn't really need to use the lower dose ones.
You answered the question already. So I personally don't use any other except the 52. There's a 52, there's a 19, and a 13. The amenorrhea rates with the 52 is about 60, with the 19 is about 35, and then with the 13 it's like 20, right? And that is actually becoming the young IUD, right? And that's how they advertise it. And then I'm taking them out because of their bleeding profile. So if you're motivated to have an IUD, I'm going to give you the one that lasts the longer and works the best. Because the insertion on itself, if it's 3 millimeters or 4 millimeters, which is actually the difference between inserters, that's not going to be the barrier there. I'll work with you. We'll make it happen, right? If you're motivated, we'll put it in, right? Some way or the other. So I don't find myself with a medical indication for a lower dose. And the side effect profile is the same. So if you're thinking of, like what's in the package insert, it's all the same stuff.
You mentioned the medications that you can give before placing an IUD, the NSAIDs and misoprostol. Is that something that should be prescribed the day before and they should take it a certain number of hours beforehand? Do you have how do you work with that?
Right, so NSAIDs, there's actually pretty good data on NSAID use prior to the procedure. You can use it about an hour before the procedure. The data on misoprostol is iffy. There's a couple of Cochrane reviews actually show no difference in ease of insertion or pain perception. That said, I have nothing else to offer. So I use it. I use 400 micrograms of misoprostol, and they take it at least 2 hours before the procedure because we got to let it work. And misoprostol has shown improvement when we're doing endometrial biopsies in adults or we're doing a DNC on somebody. It makes it more likely to be successful. For some reason, it hasn't shown in an IUDs, but, I have enough data on the other procedures that are very similar to what I'm doing that's why I use it. But at least 2 hours before the procedure. So it kicks in.
Any other questions in the room? I will unmute the phones here. A lot of people online. If you are on the line and you do not want to ask a question or make a comment, please put your phone on mute now.
The conference is now in talk mode.
All right. Does anyone on the line who is not listening to this hold music want to ask a question or make a comment? I'm going to take that as a no. Okay. I think you're good. We got hold music. Thank you very much, sir.
All right. Thanks, everybody.
Okay, if you are